Hello, and welcome to the Feeling Good podcast, where you can learn powerful techniques to change the way you feel. I am your host, Dr. Rhonda Borowski, and joining me here in the Murrieta studio is Dr. David Burns. Dr. Burns is a pioneer in the development of cognitive behavioral therapy and the creator of the new team therapy. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 30 languages. His latest book, Feeling Great, contains powerful new techniques that make rapid recovery possible for many people struggling with depression and anxiety. Dr. Burns is currently an emeritus adjunct professor of clinical psychiatry at Stanford University School of Medicine.
Hello.
Hello, David, and welcome to our listeners from wherever you're listening. This is the Feeling Good podcast, episode 384. And that other laugh you hear is our guest, Matt May.
Hey, Rhonda. Hey, David. So good to be back with you.
Really good to have you.
Yes, great to be back with both of you, too. And we have to tell our podcast audience that our beloved Rhonda is recovering and now negative for COVID. But she said she may be a little tired and boring on the podcast. And I said, Rhonda, don't worry about that. That wouldn't be different from normal. But all kidding aside, it's we're so grateful to have you, Rhonda, to start this new year. And it just I just love you and all the fantastic contributions you make to people every single day. And we wish you the best on your adventure to Germany for the next month to visit your 2 beautiful grandchildren.
Thank you. Thanks so much. And thank you, David, for your kindness and your thoughtfulness and your empathy, and the warmth that you always give to me is just a microcosm of the warmth that you give to the world.
Yeah, thank you. Thank you, Granny.
Yeah. So I thought I would read an endorsement from someone else who wants to share their warmth toward you. And I'm not sure if I can use the person's last name, so I'll just read it. And they wrote, "Hello, David, and Happy New Year. I started listening to podcast number 60 yesterday when I was walking. I finished reading your book, Feeling Great, after 1 year of studying and podcast listening. And now I've started the book, When Panic Attacks. It is always a great opportunity to know the knowledge that you present in its various forms. I think the information you give is quite precise, scientific, and specific, and that explains its absorbing quality. With the knowledge I have gained during all of these years of studying about Team CBT, I changed the life of some people in need of psychological support in spite of the fact that I'm not a psychologist. I think this is due to the scientific, precise, and specific nature of your information. Best wishes, and thank you." An anonymous listener.
Oh, okay. It doesn't even want to share the first name, right?
I don't think so.
Okay, great. Well, thank you, Mr. Anonymous, for your very kind and generous words. And I think that's one of the things that has appealed to many of us, whether you're a shrink or general citizen, is that these techniques are kind of based on common sense. And although they're super sophisticated to learn them. They seem simple, but they're actually quite challenging. But they are, kind of science-based. Every time we see a patient is a research study. We're getting their scores at the beginning and end of every session, and we're finding out what works and what doesn't work. And that process is what has really allowed team to flourish. And I can remember one of the first times, Matt, when we started measuring at the start and end of sessions, you were still a resident. And I started looking some of the start and end of sessions data on your patients, and it was shocking because I had thought you were talented, And then I saw there were no changes in the patients.
Some pretty radical worsening, in fact, symptoms after even just a few minutes with me.
Yeah, but yeah, that's right. But all joking aside, we were seeing amazing, profound changes within sessions, changes I would have thought impossible when I was a psychiatric resident. And now we're able to see changes like that on a routine basis. And it really does seem like a major breakthrough in psychiatry and psychology. And that's why we're having this Feeling Good podcast, so we can let people know what we're up to and hopefully get people a little bit excited, just the way we're feeling so excited.
Nice.
Well said, David. Yeah. And I credit you with those skills that I was able to develop. You are just a brilliant trainer and teacher.
I know.
Yeah, and humble. And so thank you for all of your generosity.
That's great. Yes, and the training is so important too, and that's where I've learned from you, Matt, and from Jill and Rhonda and the people that we've worked with. I just think we've got a great, happy family, and we give to each other and we receive from each other, and it's just a tremendous experience. I'm really proud to be a member of this group of people.
Well, and the foundation and the culture of the group is really started by you, David. So yeah, the kindness and the compassion that we show each other comes really from your values.
Shut up. It's my turn to talk.
Okay.
So much warmth.
She already said that, asshole. Stop repeating yourself.
Sorry.
Okay.
That's kind of scary. Okay, so let's jump in with a question for our Ask David.
Yes, absolutely.
I solicited some questions from our listeners, and somebody wrote in, how do you work with someone who is insistent that there are no cognitive distortions in their thoughts and that they are a victim of everyone else's cognitive distortions?
Yeah, great. Well, I just love this question of everyone else's. And let's do a little role play, because this comes right to the heart of team CBT or team therapy, whichever name you prefer, is that we have to, the main reason for therapeutic failure is not having an agenda. And so with a patient like this, we'd want to see, does the patient have an agenda? Are they asking for help? And since you've kindly agreed to play the role of the patient, Rhonda, and maybe Matt, you can be the shrink, and we can have a few exchanges back and forth, and then talk about what happened, because I love this question.
I think so too. I think it's really important. So Rhonda, you'd like to play the patient. Is that right?
Sure.
Okay. Great. I will do an average job of listening.
Hopefully,
Hopefully, at least
you don't want to set your sights too high.
That's a good point.
Well, Matt, I'm coming to you for help. Yeah, I have kind of low self-esteem right now, and I'm feeling kind of depressed. And I heard so much great stuff about you that I thought maybe, you might be able to help me. I don't know.
Uh-huh.
So now why don't we just do an empathy, and skip ahead to agenda setting?
Yeah, I would want to acknowledge your feelings of low self-esteem and depression. Thank you for coming to me for help, and I'm excited to work with you. And I'm wondering, what would that help look like if you got everything that you wanted? What would change in your life?
Well, I'd start dating, and I'd have the confidence to look for a better job, and I just really basically like myself better, more. I mean, I don't like myself at all right now, so I just like myself, period.
Yeah, that's so important. And I'd be very excited to work with you on all of those items. You'd like to start dating. You'd like to have more confidence. You said you don't have any sense of confidence right now, and that's an awful way to be feeling. And so I'm sad that you're feeling that way, but also very confident that I'd have many different methods I could share with you that could have you feeling good about yourself, get your confidence back, and maybe looking for a new job.
Yeah, great. Okay.
Would you want to roll up your sleeves and start working on that with me now, or
Yeah,
I'm
I'm
kind of
ready.
curious
Yeah.
what would be a first thing? Did you want to work on confidence first, or dating, or
Yeah,
looking for
confidence.
a confidence? Great.
Yeah.
And when was a time, like a short period of time, like 2 minutes or less, where you just felt like no confidence and would wish that you had confidence,
Well,
self-esteem?
I was I'm doing some volunteer work because I don't have anything else to do, and I was kind of afraid to go to. I didn't have the confidence to go to this meeting where they were going to orient me to this. It's just at the ASPCA because I really like animals. Um, so I had to go to a meeting to prepare for it, and I mean, I felt like even the animals would reject me because
Can I just stop for a second?
Mm-hmm.
I'm trying to relate this to the question of somebody who's complaining about everyone else's cognitive distortions. I haven't heard that theme quite yet, and you guys are doing a beautiful job of role playing how to work with somebody with depression or low self-esteem or social anxiety or something. But are you seeing that connection in your mind, Rhonda? Or
Well, because I haven't said what my negative thoughts are yet, and so I'm thinking that the cognitive distortions would be
okay, sure, okay,
within a thought.
Okay, yeah, that sounds good.
And it may be a while before we get there to that point, because I would be even once we collected those thoughts, I would pause to one kind of admire those thoughts and wonder, why would we change any of these thoughts that you have? Do you want another option, Rhonda? Do you want to just tell me that there are no distortions in my thoughts, that
Yeah,
I'm the victim of other people's distortions?
yeah, like I'm having this thought, I'm a loser, and I don't see any cognitive distortions in that thought. I mean, to me, that thought is based in reality. I mean, I am a loser. I have a lot of evidence to prove that.
Uh-huh.
Yes, I saw that about you the very first moment we met.
Yeah,
I'll shut up.
Yes, and so Rhonda, when we were trying to look at the distortions in your thought, I'm a loser, and we were looking at the list of those distortions, like labeling and all or nothing thinking. They just don't apply in this case. You've got so much evidence that, and the experience that you're having is that this is just a completely true statement. And you've described many times when in fact you have lost important things in your life, you've been let down, you've been disappointed, and you're looking at this thought, and it doesn't make sense to you that there would be any kind of distortion that we would be looking at here.
Right.
And I feel a little bit awkward too, because I wondered if maybe I was pushing too hard on this method and trying to get you to see the distortions in your thinking, and that could have hurt you. And I wondered if that was disappointing to you, or if you felt a little angry or annoyed that I was trying to, maybe I was kind of criticizing. Did you feel like I was criticizing your thinking?
Well, I just think that you're just like a really sweet, nice person, Matt, and you're really looking to make me feel better. And you're just not willing to face the reality like I am. I'm willing to face the reality. And I just got to a place of acceptance, and that's okay. I just have this place of accepting that I am a loser.
And I wonder if that I think what you're saying right now is so important is that I'm letting you down in a very important way, that you're
Well, no,
willing
I mean, it's
you're
not
willing
really.
to accept that you're a loser, but you said I'm not willing to face that reality, and I'm
You,
sweet and
Matt,
I'm
are not
nice.
willing to face reality that I'm a loser.
Yeah, and
Yeah.
I wondered if that's what that's like for you, that I haven't been willing to face that reality with you and be with you while you're experiencing that.
So
Like,
one goal, one point here is we might view this as an empathy failure, and then just go back to the 5 secrets of self-esteem that we could do, and we've done many times on the podcast. I'm wondering if we could take a different angle on it, and think in terms of agenda setting, along the lines of what kind of help would you be looking for?
right, yeah, yeah. Here it's quite clear to you that this is not a distorted thought. The idea that you're a loser. Is there some other type of help you would like, rather than addressing thoughts that are, you know, creating feelings of low self-esteem or worthlessness? Is there?
Well, I
Could we?
still want to. I still want to develop confidence and like myself more, because that will
I,
help me look for a better job and start dating.
okay,
But I've
but
heard David talk about acceptance, and I just want to get to a place of accepting that, you know, some people are winners and some people are losers, and I'm a loser.
yeah. And are you feeling joyful about that? And it's okay, and it's actually something to kind of celebrate, to be a loser.
Oh no, I don't feel joyful about it at all.
Why not? Why would you not want to feel joyful about that?
Because it's sad to be a loser. It's, it's disappointing. It's,
Why?
because if because losers don't like get into great relationships, and they don't get jobs they want, and they don't create careers, and they don't have friends, because everybody sees their yuckiness, their loserness.
Yeah, so maybe you wouldn't want to feel joyful in the context of being a loser, because you just mentioned so many things that you value and that are important to you, and they're kind of beautiful about you, that those parts of your life, you don't see those happening for you, and you wouldn't want to be joyful and happy without them.
Yeah.
Am I understanding that correctly?
Yeah, I don't think I could be joyful without them.
So what would give us the right to infuse you with joy and confidence and self-esteem in the absence of the most important parts of life?
Yeah, nothing.
So maybe the way that you're feeling right now is the most appropriate way to feel.
Oh. Oh. Ooh, my head feels like it's going to explode. That doesn't make sense. Because I want to have confidence, and I want to start dating and have a career.
Well, I think we could accomplish that. I think we could achieve that together, but I'm just seeing a lot of good things about you, a lot of positive things about you as a person, that you're feeling disappointed and sad, let down and frustrated maybe. And yeah, um, could we look at those together?
Sure. That sounds, yeah, kind of intriguing.
Okay. Because I'm seeing, when you're telling yourself I'm a loser, I'm seeing some really awesome things about you.
Can I stop for a second? How do you think this is going, Rhonda?
I think Matt's brilliant. I think it's going pretty well,
Oh, okay.
but it's also a little confusing.
I
So
think there's something missing.
I mean, yeah, it feels like there's a step missing. I don't know what it
Yeah,
is, though.
it sounds to me, Matt, that you're still trying to sell Rhonda on something, and she's kind of resisting. So I'm not seeing a sense of teamwork here,
Yeah.
or an agenda. And it might be my fault for giving you guys the assignment to do this. Uh, uh, I thought you were going to be somebody who was complaining about everyone else's distortions, Rhonda.
Uh-huh.
And I haven't heard anything about that at all. That was what this person wanted help with.
Uh-huh.
Uh,
Well, it's yeah. Um, that I'm a victim of everyone else's distortions.
yes, I haven't heard that whatsoever, and I thought that would be a great thing to work on. Now, what you guys are doing is good too, which is kind of general team therapy when you're stuck with somebody who insists that they really are no good.
Uh-huh.
And we could take that as a question too, if you like.
I think Matt's doing a really brilliant job. I guess I'm having a hard time figuring out how would I role play that I'm a victim of everyone else's
Well,
distortions.
this would be an angry person,
Uh-huh.
pissed off about the Republicans or the Democrats or the Mormons or the this or that. I mean, I don't know. I'd have to have a feel for it. At first, I thought it was your patient, so I thought you'd have a good feel for this.
No, somebody wrote me this.
Yeah. And this was a therapist who wrote you, or a
Right.
patient?
Yes,
Therapist.
a therapist.
Well, I would just write back to them and say what kind of problems is the patient asking for help with? What were their patients? What are they saying? And is this someone who's very angry? I mean, you have to
Get more specific.
Well, yeah, you have to get an agenda with the patient.
Mm-hmm.
So there are a lot of distortions, and you're right, the world is filled with hateful people and people who are prejudiced and biased and cruel and have a distorted view of the world. And is there something there that you wanted my help with? That would be my response.
Mm-hmm. Is disarming and asking if they want what they want the specific help to be.
Yeah. Right. That, in other words, this therapist is probably making the most fundamental error of all of trying to help some angry oppositional person who maybe hasn't asked for help yet.
Uh-huh.
I thought I thought what we did was useful for the negative thought that I'm a loser, but not for the thought that other people are losers.
Uh-huh.
Yeah. Well, let's continue with the working on the thought I'm a loser, because that's certainly the most common theme in all of psychotherapy that people want help with, for sure.
Yeah,
so
and the question too that this guy said that they don't see a distortion in their thought. They're seeing their thought as based in truth.
Mm-hmm.
Let me see if I can see a way of combining a victim of other people's distortions. You want to keep going, Matt?
I'm happy to. Yeah.
It's not only me who says that I'm a loser, but like the last job I had, they also, they blamed me and thought I was a loser. I did make a couple of mistakes, but not any more mistakes than other people. And, people at work thought I should do things a certain way. And, they blew everything out of control, out of perspective. And, they didn't, see the positives that I contributed. And, they put me in a category and refused to see that I was more of a nuanced person. And so that kind of contributed, their way they looked at me contributed to me seeing that maybe it is true that I'm a loser.
So it's not only you at times, or actually quite frequently, telling yourself that you're a loser, but also this last work that you did, it sounds like they treated you pretty badly. They just categorized you. They didn't really see you as a person. They blamed you a lot. They kind of focused on all your mistakes. and that reinforced your idea that you're a loser. And I notice I'm feeling kind of pissed off at them for treating you that way. And I would guess you'd probably feel kind of angry about this and hurt by that experience.
Yeah.
Probably not want to return to do that type of work.
Right.
To work with that group again.
I mean, maybe it was dumb, but I quit that job without having another job. That's why I'm looking for another job. But all the ways that they looked at me is impacting me.
And then I empathy. I'm wondering, I'm seeing a number of different ways that I could be helpful to you, Rhonda. And one would be with like feelings of anger, feeling like getting into a situation where you're being a little bullied or blamed, criticized unfairly, because that's a hard problem to face in one's life that I could help you with. Or if you wanted to continue to work on self-esteem and the sense of being a loser and the disappointment that
I don't like being bullied. That sounds good.
Okay. And then could we fast forward a few steps to get to where we've got a bullied thought, like we'd have a specific situation where you got bullied and what they said.
Yeah. Okay.
Okay.
You shouldn't have, somebody said to me, Rhonda, you shouldn't have, spoken to a client the way I did. And, you don't deserve to work here anymore. You're not as good as the rest of us.
Uh-huh. And then quick question, did you want to feel better about that situation, or did you want to have kind of a way to respond to someone when they're criticizing you?
Can I have both?
Yeah, there are different kind of methods though, and we'd have to choose one and do one at a time. Would you prefer to feel better and about that?
Yeah, I prefer to feel better.
Okay. And then we collect your thoughts and feelings, and what would be one thought that you would have that you'd want to address, or one feeling you'd want to change in that moment?
Sadness.
And what's the sad thought?
Well, when somebody said you're not good enough to work here, I felt sad. And I thought, well, yeah, that's when I thought, yeah, you're right. I'm a loser. I don't deserve to work here.
Okay. So you've got several thoughts. Let's write these down together. One is, I'm not good enough. And the other is, I'm a loser.
Right.
By the way, did you also feel pissed off when they said that? Angry, irritated, annoyed, mad?
Sure.
What were the kinds of thoughts you had when you were feeling angry or mad?
You don't have any right to talk to me that way.
They have no right to talk to me that way.
Right. Correct.
And could we also imagine that we just decided to work on that thought? And
you have no right to talk to me that way?
Yeah. Okay. Let's imagine we created a really nice agenda to work on that thought. We did outcome resistance and process resistance. And now we're into distortions.
Okay.
And Rhonda, this is just a humble technique. Could we try this method called identified distortions?
Okay.
When you're looking at the list of the 10 cognitive distortions there on the back of your daily mood log, do you see any that apply to this thought? They have no right to talk to me that way.
Well, it's really hard for me to see distortions because, anybody has the right to say anything they want. Who am I to say that somebody doesn't have the right to speak?
Okay, so I think you're talking back to that negative thought right now. Do you believe what you just said? People do have a right to say whatever they want to other people, and that's fine.
Yeah, I do believe that.
Okay, that could be a way of talking back to this thought. Could we write that down? I don't know what the distortions are yet, but I think you said that people have a right to talk to people however they want to talk to them.
Yeah. Okay.
Okay.
Right.
And then does that defeat or erode some of your belief in the idea that they have no right to talk to me that way?
A little bit. Yeah.
Okay, so that you just did the straightforward technique, and you may already have a kind of skill at doing that method, and we could measure how effective that was for you. But would you also want to look at any distortions in the thought? Are there any that you see on this list of 10 distortions, like all or nothing thinking, or other blame, or should statements, like anything along those lines?
Yeah, it's definitely a should statement. Like somebody shouldn't talk to me that way.
Okay, good. Let's write that down. And just for the sake of the role play, Rhonda, would you also want to tell me that no, there are no distortions in this thought?
Well, yeah, it's kind of hard to hold on to that.
Okay.
Yeah. I don't see any distortions in that thought. You have no right to talk to me that way. Like I just said, people have the right to say whatever they want. So what's the distortion in that?
Yeah, gosh, I'm kind of seeing a different angle here, that there aren't any distortions in that thought. Is there I feel conflicted in my mind because there's a part of me that wonders if maybe we've sort of defeated the thought and you've talked back to it and you're kind of accepting this thought and you might not want help with it.
Well, no, because it made me feel really sad and angry. And I don't want that to be repeated at my next job.
Yeah. So you would like to keep working on that thought?
Yes.
Okay. And you said that you don't see distortions in it.
Well, not yet. No.
Not yet. What if we went just one by one to look at distortions? Would you be interested in that?
Could I step in for just a minute?
Yeah, I'm feeling a little lost. Yeah,
I know, me too. Yeah. And it's really hard to hold on to this role play because I'm running to jump in and say, "Oh yeah."
Earlier on, I raised a question, and it just seems like it was totally ignored or made an observation. But it seems to me like you don't have an agenda with this patient. You're trying to help someone against their will, which is the whole thing that team is dedicated to try to get people to stop doing that. And I'm just not feeling like that there's a helpful collaboration going on here. And I think if we were working with someone, I'd always start out with, testing, get all the different emotions, and then empathy, and not move on till I got an A+ in empathy, and then find out what the patient wants help with, and then address the resistance to getting help. I would conceptualize what kind of problem the person has. Are they paranoid? Maybe they have a psychotic problem, or they're very angry, or, I don't even grasp what kind of patient this is, but then to melt away the resistance and then work together as a team. And I feel like the therapist here is trying to throw techniques at a patient that I'm not sure that we've got great empathy, and I'm absolutely sure we don't have an agenda. That's how I'm seeing it.
Right. I kind of tried to fast forward through the agenda setting and said, let's imagine we've done outcome resistance and process resistance, because I was trying to get to this moment in time that the therapist was struggling with. Yeah. And try to navigate there. And that was more challenging to get to than I thought.
Sure. Yeah. Sometimes when you've gone through resistance, it hasn't occurred to you or to the patient, why they're committed to maintaining their symptoms. You've done lip service to agenda setting or paradoxical agenda setting, but there's still resistance. And
Yeah.
this, what we're going to be working on in group tonight, is externalization of resistance, like to jump right into, go back to agenda setting when you're stuck.
Yeah, I agree with you, David. And I think I would have needed to do a little empathy in that moment, that I'm noticing some awkwardness, that we're not quite on the same page,
exactly.
or working together, and wonder
Yeah.
if there are some reasons that this is maybe not working well for them, and what that's like. I'd be excited to talk to them about their experience right now, where I'm kind of maybe missing the boat with
That'd
them.
be a great place to start if we want to do that. It's going to take a while, and we can do that if you guys want to do that. I'm just concerned it's going to take a while to move through this, and we may have lost our listeners quite a ways back. But I could be all wet, and people might think this is the best thing since frozen peas or something.
I think maybe we need to get more specific with the person who sent us this question, because it really is hard to stay in the role of wanting to reject the distortions. Like, Matt, you even had to remind me.
Yeah.
Yeah, you're very willing to work with me, and so I had to kind of try to get stuck, and then yeah. So we may have lost the listeners on this one, and we could potentially just edit that out. I don't know.
Maybe we could come back to this on. I mean, one analyst thing would be to just go to our questions here, because we've got 9 excellent questions that we can focus in on and answer. And then if you wanted to get more information from this therapist, we could address it, or perhaps have the therapist come on the show with us.
Okay.
Yeah.
And
that might be a really great idea. Okay. So let's pretend we just started now. I just finished reading the endorsement, and I'll cut all this out.
Okay.
But I learned something, Matt. I thought it was interesting.
What did you learn, Rhonda?
How you moved into that. What are the you started wanting me to positively reframe the thought, I'm a loser, and you helped me identify feelings within that thought, and that felt very that was part of the dissolving of my resistance, like looking at that thought says something great about you. It just kind of sparked my curiosity.
Okay. Well, we could potentially label it as how to help someone with the negative thought that I'm a loser. And that we could keep that segment, but maybe have Werner come on if that was his question about the client who just doesn't see any distortions in their thought, and he's a victim of other people's distortions.
That would be hard to edit.
Yeah. That's okay.
It's sort of like an all or nothing.
I'm glad there was something of value in there.
But it was valuable to me.
Okay.
But all right. So
rewind it.
Okay.
Okay.
So,
we for the edification of our listeners, we just deleted 40 minutes from our podcast that we went down a rabbit hole. And so we're going to try to redo what we were doing in a future podcast, which was a really cool question from somebody, a therapist who wrote in, I have a patient who doesn't see any distortions in their own thoughts, but they complain about the distortions they see around them and other people. And that would be a great thing to maybe invite that therapist to come on the show and role play that thing. But the issue there is, if someone's complaining about all the distortions in other people or all the distortions in the world, it's probably a very angry person who's complaining about other people. And so we could have a great role play there on how to find out, is there something this individual wants help with? Why are they in therapy? What are they looking for? What kind of help would they be looking for? Because you've got to get an agenda with somebody and get on the same team before you can help them. And so maybe that will invite that therapist back on the show and have them explain, if they feel they can, without violating patient confidentiality, tell us about how they're stuck with this patient. But you have to remember, that there's pretty much only one reason that therapists get stuck with patients and fail with patients, and that's because you don't have a meaningful agenda. We did have a nice podcast with over 20 reasons that therapy gets stuck just a few weeks ago. But it, in spite of all those theoretical reasons that are possible, that the common one that you're going to find every single time is you don't have an agenda with this patient, and that's what team is all about. Getting a collaborative relationship with the patient. Therapists think they know how to do this. They think they're doing this, but often they're not, and don't even know that they're failing in this way. Is that fair? Or?
I think so. And David, would you also say that in that kind of situation, it's useful to kind of scratch our heads and wonder, why should they have to be in therapy and working on this when other people are the ones who are to blame?
Yeah. And what brought them to therapy in the first place? Were they arrested for some violent outburst in public, or what's going on? What brought that person to you? And that's where your initial evaluation is so important.
Yeah,
what's going on with this patient?
Something real that we could help them with.
Yeah, exactly.
That sounds great. I'd love to.
Okay, you already sent the email. Yep.
Okay, so we can record that little piece that we just did, and then maybe we can have something to look forward to on a future podcast.
Very good.
This intriguing question. How about this one? Somebody, Rich, wrote a question, and we have 9 great questions from all of you folks. It was, how would you treat ADHD in team? And I'll give you folks the first shot at it, and then I'll chime in.
Yeah, I can talk a little bit about that. And David, I've had the pleasure of already reading your show notes a little bit, so I would want to just reiterate what you said there, which is so brilliant, that you don't try to treat a disorder. The disorder you can't make better or worse. It's just what it is. And but so in team, we would focus on the individual, helping the human being who's experiencing these symptoms. ADHD is a constellation of symptoms, and we'd want to know, like, when were they having these symptoms of theirs, and what was that like for them to get to know them, have a warm relationship, and create a very specific goal for the work together. And when that is in place, then we have a lot of different methods that can help someone who's struggling with attention or hyperactivity.
Yeah, that's right. And we recently had Robin Matthey on the show, and the opening on dealing with transsexual individuals. And Rhonda's opening question was a great one: is what should therapists keep in mind when you're dealing with transgender? I mean transgender rather than transsexual, but transgender individuals. And Robin's answer was a great one. You want to be warm and affirming, but don't assume that's why they're in therapy. We treat human beings in an individual way, and you find out what the person wants help with. And then the therapy becomes totally individualized. And I think this tendency to put people in boxes. Oh, you're an ADHD, so you get this formula of therapy, or you have a panic attack, so you get this protocol, or you have a troubled relationship, so you get this protocol. And team is all about never doing those things, but rather working with people individually. We recently worked with 2 people. One, we did a audio recording you can hear with Orly, who was freaked out the night of the October 7th. She was raised in Israel, and when she was coming out of the Grand Canyon and suddenly on a triumphant 25-mile hike, and suddenly her cell phone was flooded with horrific descriptions of the Hamas soldiers, these young men raping and killing Israelis. And she wanted help with that. But the session turned in an absolutely unexpected and highly personal direction, and was beautiful. And you can hear the audio of that on our podcasts just recently. In fact, I don't know if it'll be released by the time this one comes out, probably, right, Rhonda?
Yes.
Yeah, yep. And then I did a video with someone on the other side of it, an Iranian man who was experiencing extreme PTSD. And when he heard the news reports, he began sobbing uncontrollably, thinking of the people in Palestine getting, attacked in retribution by Israel, and all the starvation and the tragedy there. And then his took an entirely individual journey. We don't have formulas or packages for people. You can learn that some techniques, like the experimental technique, tends to be incredibly helpful for panic attacks. And so that's one you'd always want to consider with someone in panic attacks, but you never know where a session is going to go. And so just because someone has ADHD, I don't even know if ADHD exists, to be honest with you, as a disorder. It's, we all get distractible. Do I have ADHD? I don't know. I get real bored easily sometimes. And, but, there's just a continuum of distractibility and ability to concentrate. But the issue isn't, do you have some disorder that needs to be corrected about yourself, that you're broken in some way, but rather, where are you hurting? What does that hurting show about you that's beautiful and awesome? And how could we work together to transform your feelings right here today? And that's a very different kind of enterprise or undertaking.
I love what you're saying there, David. And in terms of that as a diagnosis, it's not pointing at something real in the same way like a diagnosis of tuberculosis or COVID or asthma are pointing to. It's really just, it would sort of be like saying you have cough, and it doesn't tell us what is the underlying cause of the cough. One person with ADHD, it might be anxiety. Another person, and that's why they're so distracted, or another person might be upset with their teacher. Maybe their teacher treated them badly. They don't want to sit still and listen to their lecture. Or another person might have eaten paint that contained lead, or they might have some other medical illness, and there does seem to be sort of genetic causes of what we're calling ADHD, but it's not really telling us. There's no place in the brain where you can point to and say, there it is on this MRI scan, in the same way you can sequence COVID or see the tuberculosis.
Yeah, and if you're treating 10 different people with this so-called ADHD, you'll have 10 entirely unique human beings with 10 entirely unique kinds of problems, needing their own individualized intervention, focusing on one fractal or one moment when they were upset. It might be a conflict with a loved one. It might be, public speaking anxiety. It might be getting bad grades. Might be anger out of being pressured. You never know what's going on with a person until you develop a loving, warm, empathic relationship and get them talking and focusing on a moment when they're looking for help. And right. And that's why team is hard, because there are no simple formulas. Like, maybe you want to be a meditation doctor. Well, then you know the answer to all of your patients. Tell them to meditate, and you can learn how to teach people to meditate in about 5 minutes, and then your training is complete.
Have you had experiences with patients that came to you and say, I think I've got ADHD, and then we're surprised at which methods were effective for them? I've had a few examples of that kind of thing. And
give us your examples. I've had very few who have come to me asking for help with ADHD.
Oh, really? I've had a couple of interesting things that came up to mind clinically. One is that I've seen folks where their learning difference or trouble with focus and concentration in school caused tremendous shame for them. And they would be very afraid in group activities in school about it becoming their turn to read for example. And so they'd be trying to read ahead, and they would become so anxious that it became almost impossible to focus and concentrate. And addressing the anxiety, the underlying anxiety, was the solution. And doing things like the feared fantasy technique, overcoming the fear of other people's judgment, and that kind of thing. And in other cases, someone coming in feeling, oh, I've got ADHD, really just benefited from some very simple methods, like little steps for big feats, or anti-procrastination, or activity scheduling. And all they wanted to do was to be able to make it to places on time. And so we just kind of did activity scheduling and worked our way backwards from, when they needed to be there. And that worked like gangbusters for them. They're now able to get places on time, and they didn't have to take any medication for it. And that could be another concern, is that there is just a tendency to throw medication at a diagnosis.
Yeah, and particularly ADHD, because what's now called medication, we used to call street drugs, namely dexedrine. There's 3 amphetamines. Benzedrine, dexedrine, and methadone. Methadone is the most horrible of them. That's the one that people take intravenously, and then their teeth start falling out, and they get premature aging and get psychotic and paranoid and violent. And then there's dexedrine. That's the second most powerful one. And we used to get that combined with amobarbital in the 1960s when I was a medical student, and you could, get some of those Dexamil pills and study like gangbusters. I think I memorized a pathology textbook in about an hour and a half after taking one of those Dexamil pills. And but now, it's promoted by drug companies as a drug, and so it's very popular because it certainly increases your concentration like crazy. But there's a downside to giving kids with developing brains a powerful narcotic like dexedrine.
There's certainly a high chance that you can have misuse of the drug, or have people trying to get the drug and sell it on the street for profit. So you do want to be.
Well, that'd be okay. That'd be a good use.
I had another situation where someone came to me saying that they had ADHD, but their issue was how it affected their social life. And they had developed social anxiety because they were afraid that their behaviors were turning people off. And it was really just a basic team structure. It only took a couple hours, a couple of sessions to go through, the outcome resistance and agenda setting and, daily mood log, and then, challenging the thoughts that they had, and then a little bit of, cognitive exposure about what it's like to join a social group.
Great.
Absolutely.
Yeah, I love that, Rhonda. Thank you so much.
And another fascinating part of ADHD to me, and also concern, I just have a huge heart for people who get some diagnosis of like a learning disability or ADHD, because like you said, it's kind of a box and a label, and it can cause a good deal of feeling defective and ashamed if you buy into it and imagine that this is my reality. It is who I am, when it's in fact overlooking the vast majority of who a human being is. Mm. And another way of looking at this illness is that it could be an environmental mismatch. A lot of people now see evidence that a million years ago, it would have been highly advantageous for humans to have more of an ADHD type of brain when we were hunting and gathering. And that when we went through the agriculture, when we 10,000 years ago began to cultivate plants, that more of almost like an OCD type of brain was more advantageous. And it could just be that our environment is not set up for success for every brain. and we may need to be looking at how can we customize learning and teaching to all people. And that's kind of what team is about too.
Yeah, that's great. I love it. Let's see if we can.
Shall we go to another one?
Yeah, let's do that.
Well, I'm sorry, I don't know how to pronounce this listener's name. Hwa-Chi Qiu wrote to you.
And the last name Alvarez, it looks like.
Yeah. They suggested an episode focused on humor and its uses impacts could be interesting. What are some strategies for when humor backfires, and how do you learn to appropriately use humor with patients?
Yeah. Well, who wants to start out on this one? We could start out on our podcast today. We've had some humor, haven't we, already today?
I haven't noticed any.
a few zany moments. And what's the use of humor in teaching, like what we're doing today?
Well, it helps relax people.
Yeah.
And it helps take pressure off people. And I think it generates a certain level of warmth among teacher-student and brings us kind of on a collegial level instead of a one-up, one-down hierarchy.
Yeah, I love those comments. What are your ideas, Matt?
Yeah,
use in therapy or teaching or whatever.
I know. Yeah, I almost always notice that if we're getting to laughter, then we're making some progress in the therapy, and you can kind of see the relief as people kick out their negative thoughts. You do such a brilliant job of that, David, by being so lighthearted and kind of playful and fun on the podcast, and it just sort of defeats my social anxiety that I'm supposed to do a really serious job or something like that, and we can just play and have fun, and yeah, thank you for creating that lighthearted feel and of just a safe place to talk and enjoy ourselves.
Yeah, I just think even on a spiritual level, part of humor is not taking ourselves so seriously. And the Buddhists even have this concept of laughing enlightenment, where at the moment that you see how distorted your negative thoughts are and that your suffering has been the result of a gigantic hoax, that you can laugh at the very moment you experience enlightenment. And I have a video of that. I know both of you have seen the Terry jumping jacks video, where she'd had 10 years of feeling like she's about to die several times a week when she gets a panic attack and thinking like she's going to have a heart attack and die. And she was in misery for 10 years and just asking her to, I induced a panic attack and asked her to do some jumping jacks during the session, which terrified her because she was sobbing. She thought, even if I stand up, I'm going to die. And then when I just pushed her real hard to do the jumping jacks, and when it dawned on her that, if she was having a heart attack, she couldn't possibly be doing aerobic jumping jacks. And she doubled over. She went from sobbing to doubling over with laughter the moment she saw that. And that was essentially the end of 10 years of misery. But she had laughing enlightenment. But as this fellow asked the question, when should you not use it? And then the other thing is, how do you teach it? I have no idea how you teach humor, but when you don't want to use it, if someone's real angry at you or angry with you, you don't want to use humor there because that will seem very insulting to them. It's like you're trying to trivialize their anger with you, and they'll typically get angrier. And you wouldn't want to use anger or humor with someone in a stage of grief and sobbing. Although I've even done that, and it's, suddenly they go from sobbing to laughter. But you have to be very careful not to hurt the feelings of the other person, because humor can have a dark side to it. And I've had people tell me, one of my former students, Jacob, told me on several occasions that when I made humorous statements, it hurt his feelings. It angered him, and he felt put down, and that was kind of really embarrassing to me, because I saw, my goodness, I've been insensitive there, and I have to be more careful, because I think humor is a powerful tool like any other, and it can be used for good or evil, and so you have to be careful that you're not hurting someone's feelings with your sarcastic or humorous statements. And every now and then I do get zapped by somebody who found I have a kind of outrageous sense of humor, and many people find it really fun, but sometimes somebody's hurt by it or feels put down, and then that's where you've got to use your 5 secrets and apologize and repair the therapeutic relationship when you do fail, for whatever all that's worth.
Mm-hmm.
I loved what you were saying there, David. Yeah.
Because sometimes people don't intend it to be, but humor can come out as sarcasm, and be subtle, like a subtle put down. And
right.
But like what you said, if that happens, and you can use the 5 secrets to repair.
Yeah, that's right. Go ahead.
Yeah. So one form of humor that I really like that you do, David, it reminds me a little bit of the feared fantasy technique, where you'll pretend to be someone who's kind of critical or doesn't like us or something like that.
Yeah.
I think that creates a sense of relief, because it's so ridiculous. That, it's so not true about you. Like, you're such a compassionate, loving person on the one hand, that's part of the ridiculousness. And then also it's ridiculous because even if we did encounter someone like that, we would just not we would be victorious, because we would no longer have to hang out with them.
Yeah, that's right. Yeah. But I just feel like our discussion on humor is
not very funny.
Well, that's true. but it may be kind of inadequate, because there's so much of this topic, and yet I don't know how to teach it or explain it. The way I found out about my humor was once I was giving a talk to the psychiatric residents at Penn, and with Aaron Beck. And I don't know what we were teaching about, distortions or the experimental technique or something like that. But I found that when I was talking, the residents kept breaking out in laughter. And I didn't quite understand why, but it was a friendly thing. They weren't laughing at me or at us, but it was like I was saying things that struck them as funny. And so I found out I can kind of blurt things out sometimes that strike people as funny. And so I've gotten into doing that, and it usually is effective, and sometimes it backfires. But that's kind of how I found my own sense of humor, that you have to find out what works for you. I can't tell a joke. I wouldn't want to tell a joke. In fact, I don't even want to hear jokes, because I don't think they're funny. When people tell them, it's kind of like a nightmare for me when someone says, "Oh, I have this joke for you," and then I have to pretend to think it's funny. But I don't. But I love spontaneously funny things, and so I think if you want to use your humor, your sense of humor in therapy, or just as a general person wanting to be more humorous, you have to kind of find out that aspect of yourself that has a sense of humor. Find your way of being humorous, if that makes any sense.
Yeah, that makes a ton of sense. And I think sometimes it's kind of it comes naturally to people, but if it doesn't come naturally, maybe people could like watch more stand-up comedians and see what it is that they like about that person's sense of humor.
Conceivably, or you can just accept the fact that you don't have a sense of humor, and that's not going to be one of your teaching strengths. And now stop beating up on yourself, telling yourself you should have a sense of humor. I think I've told the story of the FBI agent I treated who it was very depressed because he didn't have a sense of humor. You remember that story, Rhonda?
No,
I remember that story.
but it might be because I have COVID brain.
Yeah, right. Yeah, I'm sorry that you've been struggling with COVID, Rhonda.
Yeah, thank you.
Yeah, and that you're doing this podcast in spite of that.
Thanks.
And appreciate that.
But anyway, what's the story?
Well, it was a really nice guy, but he felt inferior to the other FBI agents because he didn't have a sense of humor. And and what would happen at work, they in the break, they'd go to the coffee or the water cooler and they'd sit around and tell jokes. And it was just a death experience for him every day because he didn't find jokes funny, kind of like me, and he didn't know how to tell jokes, and he didn't have a sense of humor. And so finally he came to therapy, which is a big step for an FBI agent because they're supposed to be so macho. And his thought was, I should have a better sense of humor. I should have a sense of humor. And we tried a lot of techniques that weren't helpful to him. And finally, we did feared fantasy because his worst fear was that the other agents would learn this about him and then think that he was not sufficiently macho and manly because he didn't have this sense of humor. And in the feared fantasy, he played the role of the FBI agent from hell, and said, "Gee, let's call him Clark. Gee, Clark, I've heard you don't have a sense of humor, and I judge you." And then playing his role, I said, "Oh, listen, that's nothing. That's just the tip of the iceberg when it comes to my faults."
Right.
And when I said that, he burst out laughing, and he actually laughed so hard he fell on the floor. And the funny thing was, I had shown him how to accept the fact that he had no sense of humor. And when he accepted it, that seemed so funny to him that he found his sense of humor.
Oh.
And it was that same thing that when you accept your flaws, they disappear. It's the same kind of like the disarming technique. But I'll never forget that. It was one of my favorite moments in my career. But again, his error was a should statement. I should have a sense of humor. I should be better than I am. And his salvation was the acceptance paradox. Yes, I have tons of flaws. That's just one of many. And when you accept yourself in a joyous way, that's an awful lot of what enlightenment is all about. So that's what the Buddha called the great death of the self. Because it's well known that the Buddha also did not have a sense of humor.
And that's not true at all.
I bet he had a great sense of humor.
Yeah. Actually, I think he was well known for having a good sense of humor.
That's the way I always thought of him,
Yeah.
In my interactions with him, he was always very funny.
Well, do we have time for one more?
From my point of view, we do. Yeah.
Okay.
But anyway, thank you, Hwa-Chi Qiu Ken, for that really excellent question. And we just apologize that we can't give you a better, more precise answer, because I think it's a very important question, is how can we systematize the use of humor? And aside from a few guide points, I'm afraid we didn't illuminate it much, but we did our best.
Okay, well, Rima asked, I believe rejection practice is a fine art, and I'm trying to understand the specifics a little bit more and how it differs from shame attacking exercises. David talks about some of his male patients doing rejection practice by asking as many women out as possible and collecting no's from them. The way David explains it it seems standard practice for the patients to self-disclose to the women that they are doing rejection practice and are collecting no's. My question is, if you disclose this information, would that be considered a safety behavior and may be less powerful exposure than not disclosing what you're doing? I'll give you a personal example that hopefully will clarify more. I've been doing my own rejection practice to experience how it feels for myself. One of the things I set myself was to ask someone to sing a duet with me. I found that a little daunting, so to make it easier for myself, I disclosed to a woman that I'm doing shame-attacking rejection practice, and thus would she help me and sing with me. I felt I was using a safety behavior and protecting myself from certain judgments from her. Therefore, I'm wondering if the patient disclosing what they're doing would be as helpful exposure as not disclosing.
Okay, well, I'll give you guys first shot if you like.
I'm happy to speak to that. When I'm working with people who are afraid of rejection and kind of afraid to approach someone and express their interest and ask them out, I do find it much more beneficial for them to get what I would call a real rejection, where they've made the effort to connect to that person. They're really trying their hardest, and then to get rejected, and to realize even that is okay. That even if they really fall flat on their face and fail completely, and get totally rejected after their best effort, that they're still alive, they're still breathing, and they can still go on and get another rejection later. That's more curative than some briefer types of rejection, where someone might just, if you immediately just walk up to someone and ask them, hey, will you go out on a date with me, or can you give me your number? It's almost 0% chance that they're going to do that. You're kind of ensuring the outcome because you're not putting much effort into it. And I haven't seen that be as effective as the more real failure, the more complete failure to get a rejection.
Okay, cool. Rhonda?
I don't have anything to add.
Okay. One thing that I want to point out is that rejection practice is not the same as the shame attacking exercise. And I think you have an excellent question there, Rima, but that you're confusing two things that I would prefer you don't confuse. You can do rejection practice in one of two ways. The way that Matt is talking about, really ask someone and see if you can get a rejection. And I remember when I was a medical student, another fellow named Jeff Evans. And if you're listening, Jeff, contact me. I've been trying to make contact with you, and there's so many Jeff Evans in California. I failed. But he also called himself Spider. And he was a young guy, was a aspiring drummer. But he's a really nice guy. And we went out for 2 weeks. I skipped medical school for 2 weeks, and we just went around collecting rejections between Palo Alto and San Francisco. And we must have gotten, 100 or 200 rejections. And we had 100% rejection rate. And just went up and took turns asking young, interesting young women, for their name or phone number, introducing ourselves nicely and politely, which led to instant rejection. And so that's one way to do it, or do it the way the brilliant Kai Chen developed, which is to say to women, I'm trying to get over or men, whoever you're approaching, I'm trying to get over my fear of rejection. Would you please reject me? And I've had many people who actually found that incredibly beneficial and helpful, not only to get over the fear of rejection, but also a great way to get some dates. But yes. The shame attacking is another wonderful thing that you can do. That's where you make a fool of yourself in public to get over your fear of making a fool of yourself. And so I used to, when doing workshops, take a 2-day workshop on social anxiety. I take all the therapists outside for 2 hours, have them go in small groups of 2 or 3 and go around doing shame attacking exercises. And as far as singing, I remember I was with a little group, And as we approached the hotel where the workshop was taking place, I got this other woman to go up with me and offer to sing to a couple who were walking out of the hotel. And I said, we wish to entertain you with song. And then, do you have any, requests? And this woman couldn't sing, and I couldn't sing, and they requested some song. So we belted it out a little bit for about 30 seconds and held our hands out like this for a tip, and they gave us $2.
Oh my gosh.
They were perplexed, but that's a shame attacking exercise. You don't let on that you're doing a shame attacking exercise. You just make a fool of yourself. And at the same point you made, that you find out that the world doesn't come to an end. Have you, Matt, or you, Rhonda, done any shame attacking exercises? I know, Matt, you've done rejection practice.
Yeah,
yes.
yeah, definitely done shame attacking. Rhonda, were you a finalist in the recent shame attacking competition?
No. But I've done shame attacking with you, David, when we after a hike, when we went out for dim sum, and you wanted me to ask somebody at their table at the restaurant if I could have a taste of what they had on their table. Oh.
And what happened?
I probably turned 100 shades of red, and then they're like, sure, and then they gave me a taste, and I did keep the fork, so I didn't give the fork back to them. And they were like, what do you think? Do you like that? And we had a conversation about it, and it was pretty fun, actually. And then I think we might have gone back to order it because it was so yummy.
Oh yeah. And then what did you, was that terrifying to have to do that?
100% terrifying. I thought I was going to throw up before I said anything.
Yeah, that's another form of shame attacking exercise. You go up to strangers and throw up on them. Actually, that would violate one of the rules of shame attacking.
Right.
You don't want to do anything aggressive or that would frighten people. You just want to make a fool of yourself. How about you, Matt? Have you done any good shame attacking?
Oh, every day. Most of it's inadvertent. Just walking around with toilet paper hanging out of my pants or something like that.
Yeah. Cool. I was on a Sunday hike with Miriam and Alex. And of course, my shame attacking exercise is to go on a Sunday hike because I have this low back pain. So I have to stop and rest my back every 150 yards. But we made it all the way from my house to the Roos Ridge trailhead, which is about a mile from my house. So I got a 2-mile hike, thanks to Alex and Mariam on Sunday.
Nice.
But yeah, it was nice. Yeah, I just loved both of them. And as we were leaving the parking lot, which is at the trailhead, these people came in with a car and rolled down the window like, are you leaving or something? Because there weren't too many parking places left in that small parking lot where the trail begins. And we said, no. I said, oh no, we didn't drive here. I said, we've been hiking from started early this morning in Santa Cruz, and we're heading to San Francisco. Do you know if it's much further? and they just really enjoyed it, and we enjoyed it. It was just kind of that's David's blurting out a sense of humor type of thing. But it's just fun because they responded in a really laughing and friendly way, and it's just what do you learn from a shame attacking exercise? Or what did you tell us yours, Matt?
Oh, I've done all kinds of goofy stuff.
Yeah.
Laying down on the floor in Andronico's Market was my first shame attacking exercise, and I made snow angels on the floor, and there were 2 long lines of people trying to get cheese and wine over here and coffee over there, and I was just yelling out how much I love Andronico's Market, and they have the best cheese and the best coffee. I can't believe I get to come back here and get more of their scrumptious food. I'm in heaven, and everyone just ignored me.
Yeah. Yeah. And then when you do something outrageous in public, what do you learn?
Well, part of it is that other people are kind of just have their own stuff going on and aren't intent upon judging others. That our idea that we're being scrutinized and judged at all times is hogwash.
Right.
Yeah.
Not to take yourself so seriously because other people are not taking you seriously.
Right.
Yeah. Yeah. All right. Well, thank you, Rhonda, for sticking with us during your moment of extreme exhaustion. And but it's always so neat to hang out with both of you.
Yeah.
Absolutely.
Absolutely.
And we thank all of you for listening to our show today.
Thank you, and we will see you next time.
Bye-bye.
Bye.
Bye, Barbie.
This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes under the podcast page. You will also find archives of previous episodes and many resources for therapists and non-therapists. We welcome your comments and questions. If you want to support the show, please share the podcast with people who might benefit from it. You could also go to iTunes and leave a 5-star rating. I am your host, Rhonda Borowski, the director of the Feeling Great Therapy Center. We hope you enjoyed this episode. I invite you to join us next time for another episode of the Feeling Good podcast.